My name is Dr. Brown. I'm a rheumatologist at St Vincent's Hospital in Melbourne, and as rheumatologists we look after patients with autoimmune conditions like rheumatoid arthritis and connective tissue diseases, and up to 10% of our patients with connective tissue diseases may develop pulmonary arterial hypertension, and this is an interest of mine, and I'm very fortunate that at our centre we have a screening clinic for our patients with connective tissue diseases where we may perform annual reviews and echocardiography to make an early diagnosis of pulmonary hypertension. And this is also a special interest of mine, as this is the topic of a PhD that I'm also undertaking at the moment. Exercise is a really important component of the treatment for people who are living with pulmonary hypertension. Supervised exercise programs or pulmonary rehabilitation can also be a safe and very effective way to help people who currently feel breathless when exercising. And research has shown that rehabilitation programs can teach people the skills needed to exercise safely and to manage breathlessness, and lead to an improvement in breathing and exercise capacity. The programs run for 6 to 8 weeks and often involve education sessions. Depending on where you live, there may be one-on-one sessions or group sessions available to you, and they will be targeted to achieve your specific goals. Control of breathing during exercise and at rest is processed in the respiratory centres in the brain, and this may lead to differing sensations of breathlessness for different people. There are some excellent resources regarding breathlessness and exercise, which are available on the Lung Foundation Australia website, and some webinars by practitioners who you may meet during a pulmonary rehabilitation course. Supplemental oxygen or oxygen therapy can help to increase the amount of oxygen in the blood, and therefore the amount of oxygen that's being delivered to important organs, including muscles. People with low levels of oxygen in the blood are the people who will derive benefit from home oxygen therapy or supplemental oxygen, and this may be determined using an arterial blood gas test. However, if the blood tests show that oxygen levels are adequate, then breathing extra oxygen is unlikely to be of significant benefit. In patients with pulmonary hypertension, more specifically those with low oxygen levels when exercising, research has shown that oxygen therapy can improve exercise capacity, quality of life, and can be very effective to reduce the sensation of breathlessness. We know that extensive physiological changes take place in the mother during pregnancy to meet the growing demands of the baby, and these changes particularly affect the circulation through the lungs. In pulmonary hypertension, these circulation changes experienced by all women in pregnancy lead to a high risk and unsafe pregnancy for both the mother and her baby. Although there have been recent observed improvements in outcomes, the rate of deaths in women with PAH who are pregnant remains above 20%. And this means that it's very important that all women with PAH have the opportunity to discuss this topic with their care providers and to have access to appropriate counselling and contraception. Additionally, labour and delivery also put a significant strain on the circulation, and this is mainly due to rapid changes in blood pressure and blood volume, with up to half a litre of blood entering the mother's circulation from the uterus during each contraction. And for all of these reasons, the international guidelines for the management of PAH currently recommend the avoidance of pregnancy, which can be quite a confronting thing to hear. And I really encourage anyone who is in this position to reach out for support from your doctors, family, and friends. It's also very important that if a woman with PAH does become pregnant, it's vital that they are linked with a pulmonary hypertension specialist centre with experience in managing PAH during pregnancy. Some pulmonary hypertension therapies, such as the endothelin receptor antagonists, will need to be ceased during pregnancy, and the timing and mode of delivery will also be very closely managed, as women with PAH will ideally not go into labour naturally. The highest risk to the mother is during labour and the first 4 weeks after delivery, so close monitoring will continue in this period, sometimes with a period of time in the intensive care unit, which may mean that a baby won't be with you all the time. I would really encourage everyone to watch the webinar on women's health and pulmonary hypertension, which is available on the Lung Foundation Australia website and does have more detailed information about family planning and parenthood for people with pulmonary hypertension. Following a diagnosis of PAH by a pulmonary hypertension specialist, treatment with 1 or 2 drug treatments for Group 1 pulmonary arterial hypertension will be selected on the basis of a comprehensive assessment to determine if the high pressure in the lung circulation is of low, intermediate, or high risk. The initial approach to management for all cases of pulmonary hypertension will include general measures, including advice regarding physical activity and supervised rehabilitation, as well as an evaluation for supportive or adjunctive therapy, which might include blood thinners, diuretics or fluid tablets, or supplemental oxygen, and referral to an expert pulmonary hypertension centre. People with low or intermediate pulmonary hypertension may be commenced on 1 oral pulmonary hypertension treatment with a view to the addition of a second drug after 3 to 6 months if necessary. And people with higher risk pulmonary hypertension may be commenced on 2 oral treatments or intravenous treatment right from the start. The current drug treatments for pulmonary hypertension target the vasoconstriction or narrowing of blood vessels in the lung circulation. And there are 3 main pathways which control the opening and closing of blood vessels. The nitric oxide and prostacyclin pathways signal vessels to open or to vasodilate, whereas the endothelin pathway signals vessels to narrow or vasoconstrict. By increasing the actions of nitric oxide and prostacyclin, drugs can promote opening, which in turn reduces pressure. And by blocking the endothelin pathway, medications are able to stop the narrowing and therefore promote opening and reduce the pressure in the circulation. Oral tablets available for patients with pulmonary hypertension in Australia include the phosphodiesterase 5 inhibitors, such as sildenafil and tadalafil, and the endothelin receptor antagonists, including macitentan and bosentan. And all of the oral treatments for pulmonary hypertension have been shown to improve exercise capacity, to improve the heart function and pressures, and to improve survival. The oral phosphodiesterase inhibitors, sildenafil and tadalafil, work on that nitric oxide pathway to open blood vessels. They are also thought to have some effects to improve heart function and prevent the thickening of vessels in the lung circulation. As these medications cause blood vessels to dilate, they may cause flushing and lower the systemic blood pressure, leading to dizziness, and they can also cause headache and gastrointestinal upset in some. The endothelin receptor antagonists, including macitentan and bosentan, act to block that endothelin pathway from constricting or closing vessels, and they also prevent some of the thickening that is observed in pulmonary vessels. They may also cause headache, and whilst people are taking these medications, they will require monitoring of blood counts for anemia and a review of liver function tests periodically. And that third pathway is the prostacyclin pathway, which opens the blood vessels. And previously, the only treatments available acting on this pathway were by continuous intravenous infusion or by the nebulized route. However, there is a new oral agent called selexipag, which is now available, which works to open the blood vessels using this prostacyclin pathway. In Australia, selexipag is currently reserved for people who are already taking combination therapy with the other 2 medications we've talked about. And selexipag has similar side effects to the other medications due to its effect as a vasodilator, including reduced blood pressure, headache, and some gastrointestinal upset. Selexipag is started at a very low dose and gradually increased to find the appropriate dose without causing side effects. Increased pressure in the lung circulation leading to pulmonary hypertension may be caused by a number of things, and in Australia the most common causes in the general population pulmonary hypertension due to heart diseases and lung diseases, such as emphysema or COPD, or interstitial lung disease or lung fibrosis. Pulmonary hypertension can also develop as a complication of blood clots in the lung circulation, also known as pulmonary emboli. With respect to people who may have developed pulmonary hypertension in the context of interstitial lung diseases, this is a condition which may develop over time. And most of the research in this area comes from people with idiopathic pulmonary fibrosis and suggests that up to 15% of people with idiopathic pulmonary fibrosis may have pulmonary hypertension identified in the early stages. But for most, this is mild, and severe PAH in this context is quite rare. The percentage may rise in advanced cases of interstitial lung disease, but not reaching 100% of cases. I think there was also a question about pulmonary fibrosis in the context of sarcoidosis. And so sarcoidosis is an autoimmune disease which produces small inflammatory nodules called granulomas. And these granulomas may affect the lungs, the joints, causing arthritis, the skin, and the eyes. And in 90% of cases, though, sarcoidosis involves the lungs, causing fibrosis, or affects the lymph nodes, which are quite close to the lungs. And this means that sarcoidosis may cause pulmonary hypertension due to fibrosis of the lungs, although sarcoidosis has also been shown to cause high pressure in the pulmonary vessels through a number of different mechanisms, mostly relating to those granulomatous deposits. For people who may have pulmonary hypertension associated with heart disease or lung disease, in Australia, the currently approved pulmonary hypertension specific drug therapies are not approved for use in patients with pulmonary hypertension due to heart and lung diseases, including those with pulmonary hypertension due to sarcoidosis. However, patients with pulmonary hypertension of all causes will receive the same general care measures and supportive therapies, such as evaluation for supplemental oxygen and pulmonary rehabilitation. Other systemic conditions may also be identified and corrected in patients with pulmonary hypertension, which has been shown to improve outcomes, including iron deficiency, and also some thyroid disorders can contribute to the development of pulmonary hypertension.